Good morning, everybody, and welcome to our Connect session on involuntary treatment and what are we really being asked to accept with Corey Ranger. I'm Antoinette Gravellet, and I am the program coordinator with Mom Stop the Harm. I reside in Treaty 2 territory. I invite everybody, we have a number of people on today, and I invite everybody to put in the chat where you're joining us from. And I would like to start by introducing our elder Susie to start us off in a good way. Susie?
Good morning, everyone. I'll just start with a Cree prayer, a prayer in my Cree language, and an acknowledgement that I've come to know over time and share wherever I go, and then a welcome song. Gisemandu gananaskamitan anos gagisagah. Sawen amanan gamino bimatsiah. Wichihinan ganawenamanan anos wabake madatagisagaw. Wichihinan ganawenamanan gahkanoni nanan gajwasamasa. Squawak napewak squasisak napesisak egomagahkino weneke eyapachiguda anos. Minanan and anosawen egomino machi hoen. So I want to acknowledge the ancestral territory of the Indigenous people who were and continue to be on these lands. I want to acknowledge the 600 plus Indigenous nations that were here across Canada prior to European contact, unique and distinct societies with their own languages and systems of governance, living, surviving, and thriving peoples who knew the land, the waters, the skies, the patterns of weather and animals, who looked after themselves, each other, their communities, and their nations, and who saw themselves as a part of creation and lived as such, always mindful of the generations to come. So this morning we look to the east, the south, the west, and the north. We acknowledge the Indigenous nations across the land and their ancestral story, truth, and wisdom that is carried over time to this day. We acknowledge how the story unfolded and changed over time. And we turn full circle to the east, and we acknowledge all the nations who now call this land home, those who came as visitors, guests, settlers, newcomers, immigrants, refugees, and post-contact nations. We acknowledge their story too and all that they brought here. May we be mindful of each and every one of our stories connected to the Indigenous worldview story that was and is happening here. So we give thanks for this day, for this time together, for each one of us here, for the story of each one of our lives, all that we hold and carry, and the journey that we are on. So I say, Egosane nananaskamon, kakenonewakamaganag. That's thank you. I am grateful, all my relations. And I just will sing a welcome song now, a welcome song that that is sung by an elder to welcome each new day, and also to welcome the spirit of the directions, 7 of them, the 4, and then above, below, and within. I think of the welcome song as a song that grounds us and centers us to this time together for the topic of our gathering, our conversation. I also think of the welcome song as a way to welcome whatever any one of us needs here this day, whether it's a spirit of love, of hope, of courage, of healing, of peace. And so I'll sing this song. Use my little drum here. Hey, 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 oh hey, oh hey, hey, oh hey, yeah, 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 oh hey, oh hey, yeah, oh hey, yeah, yeah, oh hey, oh hey, yeah, oh hey, yeah, yeah, oh hey, oh hey, yeah, oh hey, yeah, yeah, oh hey, oh hey, yeah, oh hey, yeah, yeah, oh hey, oh hey, yeah, oh hey, yeah, yeah, oh hey, oh hey, yeah, oh hey. I usually say in my prayer, I want to acknowledge the experience, the knowledge, and the wisdom of all of us gathered here. And so I say thank you. Thank you.
Good. Thank you, Susie. I always admire and learn so much from Susie and all of the different spaces that we come together in. And so thank you for bringing us together in a good way this morning. Thank you. I would like to next introduce Jay Stewart, who is the Mom Stop the Harm Executive Director. Jay's been with us, and I was trying to think about this. Maybe you can correct me. I think it's been about 1.5 years now. So I
That's
think,
right.
yeah. So Jay, in my experience, Jay's always been an amazing active listener whenever I've been sharing, and really has been able to hold space for me in a good way. So Jay, I would like to introduce you to everybody.
Well, thank you very much, Antoinette, for the kind and warm welcome. I'll introduce Corey in just a quick second, but I do want to acknowledge and say thank you to Antoinette for her work in the background and making this webinar today possible, and spending her time with us on the weekend to facilitate and make this a reality, as well to our board chair Tracy Letts. She's been involved with myself and with Corey for a while as we've been working in the background to put this whole thing together. So I definitely want to make sure I acknowledge Antoinette and Tracy. Say thank you very much for their help and for their support in terms of making this a reality today. So I'll introduce Corey. I guess whether you know him as the clinical director of AVI Health Community Services, or the board president of the Harm Reduction Nurses Association, or as a harm reduction educator and advocate, or as we like to refer to him, as a former Mom Stop the Harm board member and friend of the organization. Corey Ranger is here today to speak with us on involuntary treatment, and I will throw to Corey in just 1 second. We'll collect some questions along the way, and you'll have a chance to speak with Corey and make sure that your questions are posed to him. But without any further ado, it's my great pleasure to introduce Corey Ranger to you today.
Good morning, everyone. Can you hear me all right? Fantastic. So many thumbs up, so many friendly faces here today. Yeah, before I start sharing my screen, I do want to thank Susie. Thank you so much for the way that you opened up today's session. Really means a lot, and what a great way to get started. And I also want to thank Mom Stop the Harm for putting on today's webinar, for hosting today's webinar. I'm looking forward to having this discussion with you all, and we've got about 40 minutes of Corey talking, but I really hope that there'll be lots of opportunity for questions and discussions and checking assumptions. So please feel free to get those questions in. Hopefully everything works. It is daylight savings, and I have to admit that I did not account for that. So you can see my screen okay? Amazing. Okay, well then, without further ado, let's get started. Canada, as all of you know, is still in the middle of one of the worst public health disasters in modern history. Tens of thousands of people have died since 2016, and each number is someone's friend, family, community member. And so I want to acknowledge today, when we're talking about evidence and statistics, that we're talking about human beings and people that we care about and people that we cared about. And so I'm going to do my best to approach this genuinely and with a lot of thought and care. I know everybody is showing up today with different perspectives and different experiences, and that's perfectly fine. I want to acknowledge the audience and acknowledge that there are people here who have lost their children to drug poisoning deaths. There are families trying to prevent deaths. There are clinicians and advocates and activists and people with lived and living experience on the call working to keep each other safe. And so there's a really broad amount of perspective and experiences here. And so you all bring something different to the table here, and that's really important. I also want to acknowledge that this is a very loaded subject, right? And we are in a time of immense distress and urgency. The things that we see on our streets don't feel okay, right? And it's okay not to feel okay. It's a very human instinct to need to do something, to act out of urgency, to protect the people that we care about. And so a lot of the feelings and emotions that are wrapped up in topics like involuntary care are loaded, because we're talking about people that we care about and people that we're trying to protect. And so today, I want to explore a question underneath the current debate about involuntary drug treatment, and that is, what are we really being asked to accept? The goal today is to talk about evidence, ethics, policy framing. I'm going to share some of the research that I've been doing in my master's program. I'm going to share some data and some information. And yeah, this is moving beyond the debate of policy efficacy. We often get stuck in conversations about involuntary care with people saying, well, does it work or it doesn't work? And we're going to move beyond that a little bit, and I'll explain why that framing itself is a little bit problematic. But before I do, I need to acknowledge the land that I'm on. And today I'm joining from the never ceded Quw'utsun tribe territory in what is colonially referred to as Duncan. The toxic drug crisis cannot be separated from the colonial systems that create and continue to create many of the inequities that we see today. The Harm Reduction Nurses Association does work with individuals and organizations across all of Turtle Island, and we honor the life force of Indigenous people who have had their land stolen and who continue to resist ongoing genocide. Would be wrong not to highlight the fact that this toxic drug poisoning emergency is deeply connected to colonial structures, and that forced health interventions historically have been imposed on Indigenous people in these lands. And so we cannot discuss involuntary care outside of this context. Indigenous communities have long been subjected to state-imposed health interventions, and those histories matter. And those ongoing structures matter in this conversation today. And I also want to acknowledge that a lot of the content that I get to speak about, a lot of the topics that I teach on, has been made possible by people with lived and living experience of criminalized drug use, sharing their knowledge and expertise with folks like myself. many of the practices that save lives today were developed by people who use drugs themselves in the absence of larger organizations and institutions who fell behind in their response or simply chose not to respond. Harm reduction knowledge comes from people who use drugs, including overdose responses, peer outreach, safer use practices. These were all developed by communities themselves. And without this leadership, a lot of the services that folks rely on today would simply not exist. Yet the people most affected by these policies are often the least represented in policy decisions. And so I want to highlight that the voices of people with lived and living experience have to remain central in the discussion that we're having today and ongoing discussions as it pertains to harm reduction and drug policy. A little bit here, just a quick plug. I am the president of the Harm Reduction Nurses Association. For those of you who are not familiar with the HRNA, we are a Canadian national organization with a mission to advance harm reduction nursing through practice, education, research, and advocacy. We strive to achieve our mission by promoting education and continuous learning opportunities for nurses. We have a harm reduction course through the University of Victoria for nursing students and social work students. We provide opportunities to share nursing knowledge, expertise, and practices. We encourage evidence-based harm reduction nursing through practice. We create a dynamic network to support and mentor nurses across the country. And we advocate for the creation and implementation of harm reduction policies. We work collaboratively with partners to address the structural conditions that create harms. And we advocate for the rights and dignity of people who use drugs and their families. You should consider joining the Harm Reduction Nurses Association. We even have associate membership spots, even if you're not a nurse. We need it now more than ever because harm reduction is under attack. And there's a big fear of an erosion of the workforce, an erosion of the community that we have here that's working to keep each other safe. And so there's always strength and solidarity. And there's a lot of really great reasons to consider joining the Harm Reduction Nurses Association. That's the last of me trying to flog memberships, I promise. Today's conversation may touch on painful experiences, and I encourage everyone to engage in whatever way feels safe to you. We are going to be talking about drug poisonings, policy harms, stigma, involuntary detention. These are difficult subjects to talk about. And so I just want to say it's totally okay to step away if needed. These conversations can feel very personal, especially for families. And your participation doesn't require sharing experiences. My goal today is actually to do something that is not being done very much in public discourse, which is to have a nuanced discussion with you. Instead of just saying this thing is bad, we should reject it, I want to talk about what it means for involuntary drug treatment to be put forward as a frontline policy option to respond to this ongoing toxic drug poisoning emergency. And so to that end, I acknowledge that we're not going to be painting in broad strokes. We're not going to be saying absolutely not ever involuntary care for any condition or reason is off the table. What we are talking about today is involuntary care as a policy response to the overdose crisis, to the toxic drug poisoning emergency. And so we won't be, minimizing or negating individuals' lived experiences, and we won't be resorting to anecdotes or individual clinical cases. We'll be talking about the policy implications. And so I need to talk a little bit about my bias and my positionality. I am a harm reduction nurse, and I'm not going to spend too much time extolling my professional experience. Other than that, I've been a registered nurse for about 13 years and have spent that entire time working in harm reduction. I do clinical leadership and policy work, and my perspective is shaped by my role within healthcare systems and by the privileges that come from that position. I'm a white settler on unceded Indigenous territory. I do not have lived experience of involuntary care, and the voices of people directly affected by coercive treatment policies have to be uplifted and have to remain central in this conversation. The purpose of me making this positionality statement is to kind of situate my analytical lens and to let you know where I'm coming from on this. I am a master's student. I actually submitted my final assignment yesterday morning. I'm done my master's, and it's been focusing on involuntary drug treatment, and it's also been focusing on the policy implications of mis and disinformation and moral panic in drug policy. And so obviously I've been spending a lot of time in my professional, in my scholastic, in every facet of my life looking at this specific topic, which is why I'm so grateful for the opportunity to speak to you all today about it. This is overwhelming. Don't worry. This is just to scare you a little bit. So this is part of my graduate research at Royal Roads. My focus has been on involuntary drug treatment policy, but not just about policy itself, but my research looks at how policies expanding involuntary care reshape healthcare practices, ethics, and accountability, and especially the impact on nursing practice. As a nurse, I'm really interested in the fact that, institutions, bring forward involuntary care, but nurses often end up being the ones primarily responsible for enacting it. And so what does it mean when we have to violate our own codes of ethics because of legislation that requires involuntary care to be a mainstay policy intervention? Now, what I looked at within my literature is things like policy analysis, treatment outcomes research, healthcare ethics, Indigenous and rights-based scholarship, nursing governance, and this concept map that you see here shows the relationships between policy, ethics, and practice. Today, we're going to simplify this quite a bit. And instead of unpacking this entire diagram, I want to focus on the key insights that emerged. Most public debates focus on one question: does involuntary treatment works? Now, that question might matter in some circumstances, but it is wildly problematic because what individuals, people in power, policymakers believe works is defined as might be different than what you and I believe an effective policy actually looks like. And so effectiveness in involuntary care has actually already been widely studied. There's tons of research out there. And if you don't believe me, feel free to just hop on Google, because there's a lot of information that's already been published about this intervention. And so my research question shifted and became, why does this policy keep emerging despite serious concerns about its harms? And also, why do coercive or interventions that are not evidence-based become more popular in moments of crises? And the answer lies in problem framing. Policies don't just respond to problems. Policies help define what our understanding of the problem is. And so when we look at policies that are being proposed or implemented, we can actually reverse engineer the ways in which policymakers understand the problem itself. And so the reason why involuntary drug treatment is such a hotly debated subject is because it's an ill-structured problem. It's poorly defined. There is not consensus on what it means or what success looks like. And so there is inevitable ethical tensions that arise because we're not actually looking at the same issue and the same solution in the same way. Framing determines what solutions seem acceptable. And once a problem is framed in a certain way, some solutions can start to look inevitable. Conversely, when a problem is framed in a certain way, other solutions start to fade out of view and disappear. The toxic drug poisoning emergency in so-called Canada has claimed the lives of more than 53,000 people in Canada since January of 2016. And we know the drivers of harm. We know the drivers of death. The predominant driver of deaths is the unregulated nature of the illicit drug supply, the unpredictability, the volatility, the lack of agency of choice that people who are compelled to access the illicit drug supply are afforded. This is a complicated and increasingly complicated crisis. And I've shown this drug alert on my screen here because it blew my mind when I saw it being posted to social media. Pink powder sold as fluoprazolam was found to contain medetomidine. This is a different emergency than what it was in 2020. This is a different emergency than what it was in 2016. And that's because this is not an opioid crisis or an addiction emergency. This is a toxic, poisoned drug supply emergency. Because of this unpredictability and volatility and rapid changes in the supply, we are seeing more and more risk every single day. And we're starting to understand the implications of non-fatal outcomes as well, the implications of surviving a toxic drug poisoning event. In BC, a study was published just recently, and in that study, they found that people who experienced toxic drug poisoning events were 19.5 times more likely to have acquired a hypoxic anoxic brain injury because of that. And so we are hearing and seeing more about neurological injuries from drug poisonings. We are also deeply impacted by widespread grief across communities. What's important to acknowledge here is that crises can shape policy. They create urgency. They create demand for visible action. Sometimes they evolve into a moral panic, which I'll touch on in a little bit. And in British Columbia, we've been in a declared public health emergency for almost 10 years. It'll be 10 years on April 14th. And so crises change how policy decisions are made. Urgency increases and tolerance for complexity decreases. We are exiting the window of nuance now. And so in those specific contexts, solutions like involuntary care can emerge as an actual viable solution. But we have to talk a little bit about some of these insidious forces, because crises also create information vacuums. We're often really starving for answers and reasons during times of crisis. This was really on display, at the beginning and throughout the COVID-19 pandemic. And during those times, misinformation spreads rapidly during these periods of uncertainty. For those of you who don't know, misinformation and disinformation are two different things. Misinformation is unintentional. Disinformation is intentional. Disinformation has to be created and amplified and shared and believed, whereas misinformation usually happens where you see something you think is real and you share it with another person. We've also seen extreme, exaggerated narratives about public safety threats. We've seen that all across Canada. Public safety is, an ongoing narrative that is utilized to really create and grow a moral panic, telling people repeatedly, you're not safe, you're at risk, your children are not safe. They can really get people to change their voting patterns and to get them to speak out. And moral panics have the potential to actually change policy. And we've seen that a number of times across this country in recent years during the regression in harm reduction policy and funding. We've seen a lot of myths about casual drug exposure and the risk to police and the public. Stories of people walking through fentanyl smoke and claiming to have had an overdose. All of those stories and the ways that they get amplified sway public opinion. And then, of course, is made infinitely worse by media amplification and the social media ecosystem, which is about as toxic as it's ever been right now. And so then, we've been largely seeing policy being driven by moral panic and a pressure for visible action. And so policymakers, one of the things that people don't understand is that policymakers respond to public opinion, not necessarily evidence. And so in this context, coercive intervention becomes a necessity, and we can more easily accept state control. So I always use this photo here because it's one of the most really jarring examples of dominant policy framings. And what you see on your screen here is a BC Conservative candidate comparing people living in Vancouver's downtown east side to stray animals. And she said, if these were dogs and cats or pets, the SPCA would come and they would take the animals into care, adopt them out. And so across Canada, the toxic drug poisoning crisis is increasingly framed through the language of brain injury and incapacity. Political discourse frames this issue as, the loss of the ability to make decision for yourselves, that people who use drugs are a danger to themselves and others, or that they've experienced brain injury and so they're no longer able to make good decisions. And within that framing, coercive intervention begins to appear compassionate. So if you just read this article or heard this comment and you weren't thinking about the context and you weren't critically analyzing what policymakers were saying, you would think, like, at worst, this is an ignorant comment, but maybe she means well. But if you actually look at what she's saying, she's using dehumanization language, which is a key feature in genocides, and helps to rationalize violating individuals' rights. She's using rescue narratives, right? That this is urgent and we need to do this. And she's, really, who is the SPCA in the human world? We're talking about police or coercive interventions. And so she's actually saying a lot with this particular quote. And so then the ethical question shifts to intervention versus irresponsibility. And so my first question for everyone to think about is, if brain injury is the rationale for involuntary care, why are the drivers of brain injury ignored? These politicians who talk about people having brain injuries and needing to be involuntarily committed and treated rarely are talking about the drivers of those harms, the toxic unregulated drug supply, the conditions that put people at risk of toxic drug poisoning events. And so we can look here, it's not just Eleanor Sturko who's saying things like this. In my research, I was required to listen to every interview, every YouTube video, every public safety interview, and see how policymakers and politicians were talking about involuntary drug treatment. And these political quotes on the screen here illustrate a pattern of repeated language. And so let's start with the mayor of Nanaimo, Leonard Krogh. If a violation of rights means that it keeps you from killing yourself or perhaps killing others or hurting yourself, I'd say it's a reasonable compromise. Then over to Alberta Premier Daniel Smith. There is no compassion in leaving people to suffer in the throes of addiction, and we will not sacrifice our communities or give up on those suffering from addiction. Premier David Eby in BC. People with addiction challenges, brain injuries, and mental health issues need compassionate care and direct and assertive intervention to help them stabilize and rebuild a meaningful life. And Manitoba Minister of Housing, Bernadette Smith, our government is making sure people suffering from addiction who are a danger to themselves and others are stabilized and provided with access to appropriate care and treatment options without criminalizing them. And so you can see these repeated patterns of compassion, stabilization, intervention. Policymakers invoke brain injury, but ignore the drivers of toxic drug supply, repeated drug poisoning events, barriers to voluntary care, housing instability, poverty. And so this raises an important policy question. Who benefits from this particular type of framing? Well, oftentimes it's private treatment industries, pharmaceutical companies, politicians looking for quick wins on superficial solutions. Policy framing directs attention, but it hides other issues. Often the bigger, more complex issues get swept under the rug. Policy debates often also create a false binary: intervention involuntarily or abandon people to die. You'll hear this intervention versus abandonment narrative in a lot of the ways that policymakers talk about involuntary care. They're creating this false binary because then if you oppose involuntary care, then you are accused of advocating for the status quo. And then sometimes politicians just say the loud part, the quiet part out loud. And so on the screen here, you'll see where some Ontario mayors were asking Premier Doug Ford for involuntary care to help deal with growing homeless encampments. And so that's why we can't just get stuck in debates about does it work, it doesn't work, because what it works means to different people is vastly different than what you or I might actually believe a functional policy or an effective policy is. And so this common framing of intervene involuntarily or abandon people to die creates a powerful moral imperative. And then it hides all of those important alternatives. Like, we don't really have a great functional voluntary treatment system. We don't have any, meaningful and accessible population level interventions like safer drug supply programs or housing supports. And we're actually seeing a contraction in support for harm reduction services. And so it's really important to just acknowledge and say out loud that complex crises rarely only have two options. And so when you're being fed that false binary, it's imperative that you push back on policymakers and demand that they have an imagination, because there's actually an infinite amount of solutions that we could try. It's not locking people up or nothing. Across decades of research, the evidence on involuntary drug treatment is far more complicated than what these political messages suggests. And so I've looked at longitudinal studies, at systematic reviews, and the key findings are fairly consistent in that there is very limited long-term effectiveness in terms of people, being able to maintain their abstinence, and there's an exceptionally high relapse rate. There was one study that showed that court-mandated treatment was resulting in something like a 96.4% relapse rate within the first couple of months. We actually see an increase in risk for drug poisonings after people are discharged from involuntary care settings. And from a nursing perspective, what I see a lot of times and what is validated in the literature is after people have been subjected to these interventions, there's a disengagement from voluntary care. So people stop showing up to connect with care providers because trust has been eroded. And so overall, the literature does not support simple claims that forced treatment reliably reduces drug poisoning deaths. And you can see there has been at least, a couple of politicians that have spoken out in opposition to involuntary care. And so this quote with the blue highlight at the bottom is from Federal Health Minister Marjorie Mitchell. And she said, "I won't tell you that to force them to be treated is a way to solve the problem. I don't think for now we would have any kind of scientific evidence on this practice." That would be really cool, except she went on to say, despite this, we're not really going to step in or do anything about it, and we're not going to intervene if provinces go through with involuntary care. So it's, it's nice that she said something on record, but it really didn't go far enough. Involuntary care is also not new. It's anyone who's trying to package it up as something innovative or new should know that Canada already detains people involuntarily at some of the highest rates in the Western world. And so this quote comes from David Cohen from UCLA, and it was recently in a 2026 Globe and Mail article, where he says, on the face of it, Canada appears to be the country with the highest average rate of involuntary psychiatric detentions in the Western world. And so this isn't something that's a new thought, and it's also not something that we've seen a lot of positive impacts from, given the current state of our many overlapping crises of drug poisonings, homelessness, and mental health challenges. And so this is actually a repetition of existing policy, an expansion of existing policy that we already do more than most other countries. Overriding someone's autonomy is one of the most serious ethical actions healthcare workers can take. As a healthcare worker, as a nurse, I abide to the healthcare ethics and principles of autonomy, of being able to let people make their decisions and to honor and uplift their decisions and their independence, of informed consent, of proportionality, and of the least restrictive alternatives, which essentially means if you were to look at a series of interventions, you would pick the one that is least intensive, least harmful, and you would start with that. And so ethics frameworks consistently emphasize that the least restrictive alternative is a moral impetus for healthcare workers. And ethics literature also raises concerns that when healthcare workers are required to violate their own codes of ethics, there's a significant risk for moral distress, burnout, and moral injury. Around the world, compulsory drug detention has been widely criticized by human rights scholars and organizations. And I think this quote here is really salient, so I'll read it for you. Having reviewed this question from all of these perspectives, it is clear that the mass detention of up to 500,000 people worldwide under the guise of drug treatment constitutes a grave violation of human rights, and any claim that the nature of drug use or drug addiction itself constitutes a reasonable limitation on the right to liberty fails when tested. And so, there are a number of concerns from human rights perspectives related to arbitrary detention and the violation of liberty. And just because a policy has a positive intention or states that it has a positive intention does not make a system ethical. Structure and safeguards and accountability matter. We also look at from an equity-oriented lens, from a rights holder lens, who is most disproportionately impacted by these interventions. And for many Indigenous communities, policies expanding coercive health authority raises serious concern related to the ongoing structure of colonialism, the history of institutionalization and forced medical interventions. And so expanded coercive authority has shown a disproportionate impact on Indigenous people, but also on Black people, on women and gender diverse people. There's no shortage of really important publications out there that have shown that there are certain people who experience more force, more restraints, and it usually is folks who are marginalized. And so we really need to ask ourselves, when we're talking about an intervention like involuntary drug treatment, who are the victims and who are the benefactors? When governments authorize involuntary care, someone has to implement it. And this is where my research typically focused on, because it felt important as a nurse to speak directly to nurses. And so, it's a rarely discussed issue what happens on the front lines when policy authorizes coercion, and nurses are, the primary implementers in enforcing restrictions on supervising patients, managing conflict, trying to maintain therapeutic relationships, and yet nurses rarely design policy or are consulted on it. And so we already have an extremely strained healthcare system. We have an eroding nursing workforce, and the potential for moral injury and moral distress from this type of policy represents a risk to us all, because clinicians carry a responsibility. And so the fact that nurses are primary implementers, but often are not involved in SANE, and there's very little regulatory guidance, and there's very little out there to support nurses in this ethical gray area, we have what is called an accountability gap. So what are we really being asked to accept? Expanding involuntary care expands the authority of the state within healthcare systems. We're talking about state authority in healthcare. We're talking about coercive power in clinical settings, restrictions on autonomy. And so important questions have to be asked, like what kind of safeguards will there be? How will accountability be determined? Who benefits from these interventions? And what alternatives are being ignored? So the question is not just whether it works, but what powers we are being asked to normalize. I'm going to leave you with a bit of a call to action and some closing reflection. And I will just say this right now as clearly as possible. Involuntary detention and forced medical interventions is not the same as care, compassion, rescue, last resort, dignified, or evidence-based. We have to reject the false binary of intervention versus abandonment. It is deeply upsetting to see the amount of people suffering at the hands of the toxic drug poisoning emergency. It's deeply upsetting to see people who are deprived of housing and basic necessities. And so we can acknowledge that distress, but we can demand better from our policymakers. We can demand that they put forward other options, consider the structural conditions that are leading to harms. And by knowing how policy is framed and knowing what the evidence says about involuntary care, we can hold our decision makers more accountable. We should be asking who benefits from this policy. We should be demanding an accessible voluntary system before we ever consider expanding an involuntary system. We should be pointing to the structural drivers of harm. What is putting people at risk of brain injury? And how do we keep people from falling into the river instead of waiting all the way until they're downstream? We have to push past narrow efficacy debates, not getting into the, does it work? I don't, it works for me. And most importantly, we need to uplift the voices of those most impacted by the policy. And so show up at your city council meetings, write letters to the editor, push back where you see this framing that is constantly being employed by policymakers, because we're smarter than that, and we can figure this out, and we can actually demand solutions that reflect the complexity of this emergency. Everyone in this room wants fewer funerals. Everybody here wants safer communities. Crises create pressure for fast solutions, but history shows urgent policies can create unintended harms. And so the core question here is not whether we act, it's how we act and what values guide that action. I've included a few resources here for anyone who would like to explore these issues further. There's a fantastic article from Ewan Thompson and Zoe Dodd called Media Politicians Are Rebranding Coercion Against Drug Users as Care. There is a call to action from the Harm Reduction Nurses Association and the Doctors for Safer Drug Policy called We Refuse. And if you're a healthcare worker watching this, you can still sign your name onto that petition. And there's a wonderful study out of some great clinicians in Alberta titled Involuntary Treatment for Substance Use, Application of CAS's Ethical Framework to Alberta's Compassionate Intervention Act. Several of these resources also offer deeper discussions about alternative approaches and ongoing debates. And so, yeah, this is a great place to get started if I've managed to pique your interest in this 40-minute discussion. And I hope today's discussion contributes to thoughtful and respectful dialogue about how we respond to this crisis. Thank you.
Corey, excellent. Thank you very, very much. Really, really appreciate that. We're going to move into some questions in just a moment here. I would encourage you, if you do have questions, please, by all means, feel free to put them in the chat. I will work with Antoinette and we'll sort of extract some and try to, if I see some themes, I'll try to tie some things together to put those questions in front of Corey. Maybe Corey, one before, there's a few I've got kind of at the ready here, but one I want to ask you with, if people are looking for a slide from this presentation, will this be made available in some place? Is this going to be somewhere where members can access? I know we will have this recording available on YouTube later, but the actual slides themselves, are they available in any place?
Yeah, I'll just PDF it and send it to Antoinette, and she can send it out to whoever wants it. This isn't the first time as well that I've presented on this. So the Harm Reduction Nurses Association has a much longer recorded webinar where we actually had a nurse historian talk about Canada's history with involuntary care. And so I can share links as well and extra resources and pass them on to Antoinette if you want to package them up and send them to attendees.
Wonderful. That's perfect, Corey. Thank you very much. So we're going to have about a little more than half an hour to sort of take your questions. And again, I encourage you to please put anything you'd like to have posed to Corey into the chat, and I will kind of go in and collate and pull some things there. And then at the very end of our time together, our board chair, Tracy Letts, will introduce the organization's position statement on involuntary treatment and share that with everybody here. So we'll save some time for Tracy at the very end, but definitely want to make sure that we centralize your questions from folks. And maybe one that I would kind of kick things off with, and I've had the pleasure of seeing Corey present and speak before, and I really like his sort of distillation of that kind of like kitchen table kind of talk in terms of having good key messaging and thoughtful commentary on maybe how to have these conversations with, maybe that ordinary old uncle that you don't necessarily see eye to eye with, or the people around, your communities. But Corey, I think that it's safe to say that public perception often shapes policy, and I'm wondering what, in terms of those conversational key messages about harm reduction and voluntary care, what do you believe are the most important for families and for the broader public to understand when discussions about involuntary treatment arise? What are some of the key messages you would like to impart upon people to have these kind of conversations?
Yeah, I think that's wanting to really toe the line on my own recommendations to get away from narrow efficacy debates. And so when talking about key messages, don't talk about what it doesn't do, talk about what it does do. And so we know that these policies disproportionately harm Indigenous people, Black people, people of marginalized genders. We know that that involuntary drug treatment will not address the root drivers, and that includes the unregulated drug supply. Evidence has shown that involuntary drug treatment has a significantly high rate of relapse, and it does nothing to address homelessness or the housing crisis. The most likely outcome of involuntary drug treatment is losing someone to care and to not being able to see them anymore, because when trust is eroded between healthcare systems and people who are at risk of drug poisoning, people stop engaging. And so I think really focusing on not getting into nitpicking about, what someone says or trying to debunk what somebody says, but going into like what we know these policies do, and then pivoting to, let's talk about solutions that are going to help keep people safe. Let's talk about solutions that are going to make sure that everybody has a chance to be safe. And I think when it comes to having those kitchen table conversations and those difficult conversations with loved ones, what I've come to learn is just relying on evidence and data can actually result in a bit of a backfire effect, right? Like people are very sunk into their specific identities and their beliefs and their opinions. And when you present them with a bunch of data
And you're not.
that contradicts what they're saying, that doesn't just win over hearts and minds. And so instead, trying to find those mutual connections, those shared understandings. And so if someone is saying like, oh, I can't believe, how terrible things are out on Pandora or on the downtown east side. And they think that involuntary care is a solution to that. Instead, trying to bridge that person first, right? Like, hey, I'm really uncomfortable with what I see on our streets too. I feel a lot of discomfort when I see people experiencing prolonged sedation, when people are incapacitated on the streets for hours on an end. That makes me feel very uncomfortable also. Let's talk about what we can do to make sure everyone can be safe. And then start talking about safe supply programs, start talking about voluntary access to treatment, start talking about housing as a human right. Yeah, I'm uncomfortable with how many people are subjected to the elements and are left outside. Let's talk about how we can make sure everybody has a home. And so trying to bridge people in, validate the distress, provide empathy is a great disarming tactic versus just, that's not what the evidence tells us. Typically results in, a bit of a one-way conversation.
Awesome. Thank you, Corey. Something else I know that you had touched on and spoke about in your remarks about sort of I want to go back to the ethics and autonomy piece of this equation a bit. And I think we recognize that, forced or coercive treatment raises serious human rights issues and questions. What if you could maybe just revisit the ethical concerns that you see as most clearly when involuntary treatment is proposed or implemented for people who use drugs? If you could maybe kind of revisit some of those, those ethical and autonomy questions, because I think those sometimes are central to this kind of debate and conversation.
Yeah, I mean, and there's been studies that have spoken to people with lived and living experience about their experience of going through involuntary drug treatment. And some of the key themes that have come out of those studies have been people who use drugs largely felt like it was an intervention aimed at controlling their ability to make decisions. And so people who are in the margins, who face a ton of structural violence, are also chronically disempowered. They have their decision-making authority taken away from them. They experience paternalism from the nurses and the doctors that they are seeking help from. At every turn, they have their power stripped from them. And so this is just a further expansion of that pattern. And what we really need to be doing is trying to find ways to empower people, to build people up, to give them the information that they need to be able to make informed decisions. And so, when we take away someone's autonomy, when we take away someone's ability to consent, we are stripping away their basic human rights. And that is not proportional given this crisis. And so the ethical implications, there are a number of ethical implications when it comes to involuntary care. And really, it falls back on that intervention versus abandonment false dichotomy. But there's a lot of other options other than abandonment.
And Corey, I think that one of the I'm sorry, I was just pulling some questions up from users here. And again, please, if there is anything you'd like to have post to Corey, please dump those into the chat, and I'll pull those out. One user question, Corey, was we know that involuntary treatment is not new. It's been around for a while, but are you able to speak to the number of people who may be caught up in involuntary treatment, specifically pertaining to their substance use?
Yeah, and I don't think we have great numbers. There's not a lot of transparency or accountability when it comes to these systems, and so what I would really direct people to is an organization called Health Justice. which has done a ton of really great work in exploring the subject of involuntary drug treatment with a very nuanced lens. And they've got some great publications on it, but I don't have like right in front of me specific numbers on the amount of people. I can tell you, based off of that report that I had previously brought up, that detentions in Canada for involuntary care, there's about 317 detentions per 100,000 person annually in Canada. And that represents the highest average rate in the quote unquote Western world.
And Corey, I'm wondering if we've heard this sometimes from members. I mean, we'll get to this at the end, but I mean, this is it can be a polarizing topic within inside the organization. How might you respond to somebody, potentially a parent, that says, this, I support or I believe in involuntary treatment because my loved one today, I know where they are, or I know that they are safe, or I know that they are secured, or what people who might sort of view this through the lens of peace of mind. Any thoughts or response to that someone who may hold those positions or may have that line of thinking?
I mean, right out of the gate, I hear this from people all the time, and there is not consensus. Even when I go through a lot of the disproportionate impacts on Indigenous communities and its ongoing relevance to colonialism, there have also been First Nations leaders who have come out advocating for involuntary care, and a lot of times people are in a place of extreme desperation when they've seen their communities decimated, when they've seen their children be harmed, when they read the stories about the level of toxicity in the drug supply. Everything you read is, you need to wrap this person in bubble wrap, and you need to get them somewhere safe right now. And oftentimes we believe that involuntary care is the option because there isn't anything else out there for them. And so we resort to these interventions. And so, like, you have to acknowledge the distress, the very real distress that people are experiencing when they're making statements like that. They're, in their mind, this is safety for now, right? And so we can't just say, well, that's not what the evidence shows. But we do need to help bring people along. We do need to talk about, what the actual implications are of these interventions. There was a study that was done that actually spoke to parents whose children had gone through involuntary drug treatment. And even in that study, which hint that the title of the study is called Grasping at Straws, at the end, the outcomes of that study was that the parents who had put their kids through involuntary care were disappointed with the results, and mostly disappointed in the fact that it didn't manage to sustain any kind of abstinence. And so I think we have to do that disarming, bridging, accepting that this is a very real fear that a lot of people are having, before we can shift into, okay, now let's talk about, what we know. Let's talk about the disproportionate harms. Otherwise, yeah, you're missing out on a huge variable in how someone's showing up in that discussion, and you can put them off. You can come across as dismissive, and all of that just pushes people away and restricts our ability to build bridges.
Hey, Corey, I'm going to encourage everyone again to please put questions you'd like to pose, Corey, into the chat, and I'll be happy to kind of pull from there. I did see someone ask a question about Mom Stop Harm creating a document of speaking points on this. So again, we'll have the chance to sort of throw to Tracy at the end of this time together here today to discuss or to present and share Mom Stop Harm position statement here with everyone who's in attendance. So we've got around 21 more minutes left. I will save some space for Tracy back at the end. And by all means, please do put your questions into the chat. And I'm going to pull one out. right now. This is speaking about sort of the intersection with folks with severe brain damage and the special reports that some folks may require. And this is kind of be a question about I think the resourcing and the spend. But would the member ask, would community living style places instead of hospital or jail style help folks stay on meds, eat, stay housed, have a safe place, teach life skills, whether they're on a recovery path or not? Wondering if you could speak to a little bit about sort of a better utilization of those kind of that kind of time and money, those kind of resources question, Corey, about how that may be better allocated or deployed in pursuit of what we're speaking about here today.
Let me see here. Remember to ask, would community living style places instead of hospital or jail style? I mean, yeah, we need to see every possible option, particularly options that are evidence-based, that are accessible, that are voluntary, that are regulated, on the table. And so there's a distinct possibility that some of those types of spaces could produce better results, as long as we're aiming for a non-coercive approach to them. I think that there are a number of ways in which coercion creeps into healthcare, and so it's not always as black and white as people being put into jail cells. But yeah, I do think that that's a potential viable option for sure.
Understood. Another member question here of what recommendations do you have in educating Indigenous leaders about the implications of forced treatment or compassionate intervention?
Yeah, I think that we need to honor Indigenous rights to self-governance and acknowledge that there are a number of different perspectives and priorities within communities. And the worst thing that we can do is show up in those spaces and say, you're wrong about this, or you don't understand, or this is the way to move forward. And so instead, we really need to focus on taking their lead and showing up and saying, what do you need and how can I help? And helping to grow from there. I've had some experience working in different Indigenous communities where we've started all the way at the basics, which is like, why is OAT okay? Why is it okay to give people methadone when they have an opioid use disorder? And really starting from the ground with that, rather than showing up and being another paternalistic healthcare worker or advocate trying to dictate how communities support each other. Otherwise, again, yeah, we're not gonna make very much traction.
And Corey, I'm wondering if you can kind of speak to any sort of success metrics that anyone might sort of speak to that the position of involuntary treatment can be successful. People are there's numbers that support these types of positive outcomes. Wondering if sometimes you hear about sort of this rock bottom argument, this debate. How might you counter an argument that says that involuntary treatment can be successful, if you would counter that?
Well, there's people who have gone through it and who have lived experience of going through it and will claim that it was a huge difference maker. There's a little bit of survival bias that happens where some people might actually experience some benefits from a statistical standpoint. Most wouldn't. But really, success criteria and talking about that rock bottom mentality, oftentimes success from policymakers is just like the number of people who get access to a system, but we're not looking at what the impacts are to that individual long term and what the implications are of severing someone's trust from the healthcare system or from care providers. And it's really important to share with people like that rock bottom mentality in the context of a toxic drug poisoning emergency. People don't bounce back from rock bottom anymore because one bad batch, one relapse following a period of non-use, which forced abstinence would result in, means that rock bottom is 6 feet under for people in today's current toxic drug supply.
Understood. Again, we'll come back to some more questions from members in just a second here, but if you did have anything you'd like to have presented to Corey, please put those into the chat. I'll be happy to share with them. And again, we'll come back to Tracy just in a couple of minutes to kind of wrap things up and share our position statement with the folks in attendance here today. How, Corey, do you find available evidence? When you touched on this a few times thematically, but how does the available evidence compare with the narratives being used to justify these policies?
Well, I mean, we're talking about the narratives that come up in policy discourse, which is often about rescue, about stabilization, about this being the last resort. But in reality, you know, we're looking at an intervention that has a high probability of increasing someone's likelihood of dying by a toxic drug crisis. And so I think I've already spoken on this a few times, but thematically, well, this is why we can't get into those narrow efficacy debates so much, because the evidence is showing limited long-term effectiveness, high rates of relapse when people leave these settings, an elevated overdose risk, disconnection from health and social services, which completely runs contrary to what we're seeing from politicians in their framing and the way that they're messaging these interventions.
And Corey, I think a lot of times in life, it can be as simple as sort of following the money. So this is a question that was posed in the chat about sort of the financial underpinning. So the question is, you spoke about public's perception shaping policy. What emphasis do you think that the financial impact has had on shaping policy?
Well, that would be me probably trying to look into the tea leaves a little bit too much. I always believe in following the money, but I can't say that that's been a huge focus in my research, and so I don't know if I can specifically speak to that one.
No problem. A question from someone from Saskatchewan asking about the provinces. Have you heard about the provincial government in Saskatchewan bringing their Compassionate Intervention Act in? What are your thoughts on this?
I think the Compassionate Intervention Act is, it's the same language that's being used in Alberta as well. I think that we're seeing provinces across Canada, regardless of their political affiliation, start to expand or seek expansion of involuntary drug treatment. I want to go back to the nuance of the purpose of today's discussion wasn't to say, this one thing is bad and we can't do it, but as a response to the toxic drug poisoning emergency, as a frontline policy, that it is definitely something that we know is not going to have the impact in terms of keeping our loved ones safe. And so, the whether it's Saskatchewan or Alberta or British Columbia, we're seeing different iterations of these legislations start to be rolled out. And they all have very similar framings and very similar pathways. And so, it's I would be equally concerned about the one in Saskatchewan as well.
Understood. A couple more minutes left, and again, maybe a last question or two. If you want to post those in the chat, I'll be able to pull those up just a second. But one more question, kind of on the resource capacity side of things. A member asks, if we don't have enough healthcare staff as it is and not enough housing, where and how are we even going to be able to do all of this, Corey?
Where and how are we going to be able to do all of this?
Looks like the question is pertaining to the capacity, the limitations of, how sort of underwater the healthcare system is in general, how over capacity, under resourced, understaffed, all the kind of laments we hear quite often in the media. I guess the question pertains to that. If we don't have enough, healthcare staff as it is right now, how can we possibly apply those meager resources that we do have to this current situation?
I mean, yeah, it's a very complicated question, and so like looking at what exactly is putting a strain on our healthcare system. We are dealing with multiple colliding, overlapping crises of homelessness, of unaffordability, of mental health, of drug poisoning, and it's very inefficient to wait till people are already experiencing all of those harms and seeing them in the emergency department. And so we really need to see prioritization of investment in our public health system and in keeping people healthy and keeping people safe and keeping people housed, so that we can reduce the strain on our healthcare system. But that's a very complicated question for sure. And the answer would probably require another 20 to 30 to 40 minutes.
Yeah, we're gonna ask you the heavy hitting questions, Corey. We're gonna keep you on your toes here this morning. So this is some big ones coming at you there. We're gonna wrap in just a quick second here. I want to make sure I do save some time for Tracy to speak with her about our organization's position statement. Before I do that, however, maybe Corey, one last thing. If there was one takeaway you would like everyone to kind of leave from this conversation here today, and share with friends or colleagues, neighbors, whatever the case may be, what is there one central takeaway, one big theme that you would like for folks who joined us here today to reflect on after our time together this morning?
Yeah, I mean, I would just go back to those calls to action and really asking people to challenge our policymakers when they make very superficial, short-sighted suggestions or statements in the media, to hold them to account on that and to ask them questions like, how will involuntary drug treatment address the toxic drug poisoning emergency? How will involuntary drug treatment get our loved ones housed? Because that's where we need to reframe the debate around. That's where we need our leaders and our policymakers to be focusing on. And so, yeah, don't accept the dominant framing that's put forward to you. Critically think for yourself and to demand that nuance from our politicians.
I love everything about that, Corey. Thank you very much. So maybe as we move towards the wrapping up here, I think that you can see that this can be a polarizing topic, and certainly not one that every member of Mom Stop the Harm might agree on. And I think this is has caused our organization to reflect and think deeply on its position pertaining to involuntary treatment. And I want to acknowledge the efforts of our board chair, Tracy Letts, who's led our efforts in concert with our board of directors in thoughtfully drafting a Mom Stop the Harm position statement on involuntary treatment. And it's my pleasure to introduce Tracy to you right now to speak on that, and I'll throw it over to the boss there, Tracy.
Great. Thanks, Jay. Thank you, Corey. Every time you present to us, I always learn something new. And we're really honored to have you here today. This is a conversation that is just happening across the country in so many ways. And it's, like Corey has framed it or spoke about it, is that they're so open to misinterpretation of what it is, but the messaging around it is that this is something we're all asking for. This is something we want, and they're creating that message, whether it's within media, etc. So one thing that Mom Stop the Harm, we really thought about, because this conversation is happening so often, and we're really felt that was necessary to kind of get our perspective out there, because they are framing it, because they're using families to justify these policies. And but they're using families to help justify these policies. And we really wanted to put our perspective in on what is happening and how, as an organization whose family members have all been affected by this crisis. So we felt very important to bring our perspective that is grounded both in evidence, lived experience, and to remind decision makers that the real gaps are in the access to a voluntary system, harm reduction, and a safer drug policy, safer drug supply. Sorry, it's really hard to follow up after you, Corey. You're such a great speaker. So we did draft three positions, one position statement. We've divided it into three. We have a longer version, a short version, as well as just some speaking points. But our initial statement, in basically the first part of that, has some context about why we felt it was necessary from a Stop the Harm perspective to put this out there, and to discuss what the emerging evidence is. Basically, that there is no clear evidence that involuntary treatment reduces overdose deaths, no consistent evidence of improved long-term recovery outcomes, increases the risk of overdose following discharge in some settings, and reduce trust and engagement with involuntary health services. We kind of touch on different points in here. We bring up the human rights and dignity issue, which we feel that is one of the most important parts around this. And I don't know, were you able to put it in the chat?
Yes, it's in the chat.
Yeah, it's in the chat. Okay, sorry about that. So we do have a longer version that we will be releasing, and it's going up on our website, and it will be going out to all the members as well as on our social media. We have a shorter version that has some talking points in there, but we also put out there's a quick 30-second media statement of something, just kind of touch on some points if people were ever asked about it. But we also had some guiding statements that we used when creating this document. Because as an organization and families, we know the pain, anguish, and heartbreak of losing a loved one. And we also know that fear-driven policy can cause unintended harm. And I think that is kind of what we bring this all back to, is the unintended harm of a narrative that is being spread without the voices of everybody who's connected to this. So, sorry, I'm having a hard time speaking to this right now. This is something that is near and dear to a lot of us. A lot of our members within this organization have had loved ones that have experienced involuntary care. We have had board members that have experienced voluntary care. We recognize the harm that has caused, and it is coming from a family perspective, or coming from an organization such as ours, whose voices were not included in a lot of these policies, who we were never really asked. The media reaches out, but it's the messaging that's getting out there is coming from a perspective where they're basically, it seems like the messaging is coming from, this is what families want. This is what people are asking for. And so we just want to provide a different perspective on, maybe this isn't what we are asking for. What we're asking for is a robust system of voluntary care, addressing the gaps, the root causes, and everything that goes along with that. And just like, if you take time to, like, Jay brought it up, it's a polarizing subject, but we feel very strongly that the unintended harms of involuntary care are not something to be overlooked, have to be spoken to, and we needed to add our voices into the conversation. So if you have any questions about the position statements, please reach out to us, let us know, and we can answer anything that we possibly can.
Thank you very much, Tracy. Yeah, thank you, and to the board for putting your time and energy and into drafting that and getting that together for everyone who's joined us here today. So thank you very kindly for that. Just in our sort of closing moment or two here, I definitely want to acknowledge Paige had made a note in the chat there. Really glad she did, flagging a specific episode of the Crackdown podcast, our good friends over at Crackdown, episode 54. This does a really, really great job speaking to involuntary treatment. So if you've not listened to that yet, I would encourage you to listen to all the Crackdown podcasts, but definitely give that a listen. And I think you'll always find something really really informative from Garth's opinions and the folks at Crackdown. They do a really great job. So a little shout out for those guys. So I guess in closing, I just want to say thank you very, very much again to my colleague Antoinette, to Tracy, Shauna Zagaro, to back behind the scenes, our board members, and especially Elder Susie, who brought us together here today to open today. in the way that she did. So I want to acknowledge and say thank you to everyone who kind of leaned in to make today possible. And certainly, last but not least, Corey himself, very, very, very busy guy, smart guy, awesome guy. Really appreciate him taking the time to work with us and step into this space and help kind of shape our thinking. It's a big topic, and Corey's been just a real pleasure to work with all along the way. Just been really, really grateful to have this chance. So Corey, thank you most sincerely for taking the time to work with us here. And again, to all of you, thank you very much. I know it's a bit of a weird day for some folks with daylight savings time and whatever time it is this morning or this afternoon, or where you may be joining in from across the country. But thank you for taking some of your time on a Sunday morning when you could be doing other things to be with us here today. And if you are interested in finding out about future upcoming Connects webinar sessions that Mom Stop the Harm put on, make sure you follow us on social media, follow your email, and we're going to have other sessions like this coming up. We're going to keep doing these over and over and over again. I think these are important forums and community conversations to have with one another. So we have another one coming up on May 24th. Yes, May 24th, with Dr. Holly Mathis on unpaid family caregiving or caring research and findings, and other opportunities to kind of engage with Mom Stop the Harm and other members along the way as we continue to roll out our Connects webinars. So with that being said, I will bid everyone a happy Sunday. Again, thank you for making the time. Again, Corey, to everybody, it's been a real pleasure. And thank you very, very much, everyone. Enjoy your Sundays, and we'll talk with you soon.